This is Lecture 5 on Chapter 22, GI Disorders, and you'll be glad to know this is the last one. So, intussusception. This is a telescoping or slipping inside of one part of the intestine into another. Most often this is on young children, 3 months to 3 years, and it usually happens at the ileocecal valve, which makes sense because you've got the large intestine is much bigger than the small intestine, so the small intestine slips inside. The problem is when it does that, it stretches and pulls and pinches off the blood supply, and ischemic tissue is very painful. So you get, terrible abdominal pain, vomiting, current jelly stools, and that is characteristic of intussusception. If you've ever had current jelly, it's kind of a red-black jelly with some little bumpy pieces in it, and that's what the stool looks like. So if this child passes a normal brown stool, it means the intussusception resolved. It reduced itself spontaneously. It slipped back out. The way we diagnose is also the first attempt at treating. We do an enema. It used to always be a barium enema, but now sometimes it's air or water or something else. But by putting the enema in, you're putting it in that large intestine, and it will push out the small intestine that has slipped in. So we're able to, with that barium, it shows up well on X-ray or imaging, and we're able to see what it was and push it back out at the same time. And most of the time, the majority of the time, that treats it. If it doesn't, they may have to go into surgery, and the surgeon will grab the two ends of the affected intestine and pull them apart. So they're manually reducing it. And here's a picture. You can see this is the large intestine that should be coming down here, kind of slipped in with this small intestine in here, and you can see how those blood vessels get all yanked and kinked, and that's where the can be a problem. Malrotations and volvus. This is an abnormality in the whole intestinal system. The way it's designed, the structure of it happens in utero. Malrotation, it can, something is not where it should be, and it's at risk for twisting around on itself, which is a volvus. It totally pinches off the blood supply. You don't get blood to tissue, you get dead tissue. Dead tissue, there's nothing we can do to bring it back to life. All we can do is take it out. And it will, dead tissue will perforate, and then the germs in the gut spill out, so you get peritonitis as well as necrosis of that tissue. This is how kids can end up short gut syndrome, and we'll talk about that one a little later. Malformations of the anus or the rectum. Atresia means it's not working at all. Stenosis, it's there, but it's tighter than it should be. Either of these are going to probably take surgery to release that tightened sphincter. Stenosis, if it's not too bad, they may just be able to stretch it out, but they often have to surgically kind of snip it. Imperforate anus. There is no anal opening. Sometimes there's a fistula to something else, usually the urethra, but there is nowhere for stool to come out, right? Incompatible with life. So this child, right after birth, is going to get a colostomy, so that stool has a way out. And then we're going to let them grow, and when they get a little bigger, they'll try and reconnect and create an anal sphincter. Celiac disease. This is somebody who cannot tolerate gluten. This is kind of hip among a lot of celebrities and things to try gluten-free diet, but if you have true celiac disease, you have no choice. You must follow a gluten-free diet. Eating gluten does damage to the villi in the gut, and then you have all sorts of malabsorption because those villi are, now don't absorb other things. It's not just the gluten. So this is a permanent thing. It's not something you will outgrow, and it is a very strict diet and has to be followed for life. the 4 characteristics: steraturia, which is big fatty stools, malnutrition, abdominal distension, and vitamin deficiencies. And here's a schematic. So normally we eat things with gluten, which the biggest culprit in our diet is wheat, but also rye, oats, and barley, and they break down into a substance that you're able to absorb just fine. If you're not able to break that down, it turns into a substance that is toxic to the villi and destroys the epithelial cells of the villi, which is where your absorption happens. So it causes this malabsorption syndrome. When you don't absorb fats, you get steraturia. When you don't absorb proteins and carbohydrates, you get malnutrition, and which will also lead to peripheral edema. If you don't absorb calcium and vitamins, you get weakened bones, osteoporosis. If you don't absorb vitamin K, this affects blood coagulation. If you don't affect iron, you get anemia. So it really has across the board, huge amounts of it affects all your systems basically. So what happens in those small intestines? You get this mucosa that cannot absorb initially the gluten, but you do damage and then you can't absorb most anything. So where is gluten? The big culprit in our diet is wheat, but it's also in barley, rye, and oats. And if you're not absorbing, you get failure to thrive. And over time, this is going to cause diarrhea because everything's just moving through and not getting absorbed normally. You must follow a gluten-free diet. So what grains can you eat? Well, rice and corn. So things made with rice flour or cornmeal are okay. You notice there's no fruits and vegetables up there. Those are all grains. So fruits and vegetables are fine. It's just products with grain you have to be real careful about. And unfortunately, most of our packaged and prepared foods have some grain additives in them, such as hydrolyzed vegetable protein. So they've got to be careful about all those additives because they have bits of wheat or barley or rye or whatever. This damage they do to the villi usually will also make them give them lactose absorption issues, but that's temporary. So they're not permanently lactose intolerant, but until the villi heal, they are. Short bowel syndrome. This, at Children's, you're going to hear people call it short gut syndrome. Same disorder. This means you do not have enough gut to absorb enough nutrients for life. Usually this happens. The most common is NEC, so necrotizing enterocolitis, which happens in our preterm babies, where some of the intestine becomes necrotic. Necrotic stuff is dead, has to be removed. What's left is not enough to live on. Volvus, that abnormal structure at birth, which then twists around and pinches off the blood supply. Children who have gone through radiation, those can all cause it as well. I've seen gastroschisis, things like that cause it as well. So this is somebody who is TPN dependent. They cannot get all the nutrients they need through the gut, so we must give them TPN, which is IV, giving them, nutritional support through the IV. In your charting for me, I really like TPN put with IVs and any enteral feedings put, in GI. And that's just because I want to make this big gap in your mind between things that are sterile, that go into the vein, and things that are not sterile because they go into the gut. They're hardly even clean, right? The gut is dirty. It's not even clean. But they're both for nutrition. So I know some places they combine those two. I just like to separate clean and dirty very far apart in your minds. We try and do as much enteral feeding on these kids as possible. We usually put in a G-tube and have some G-tube feedings or perhaps continuous feeding at night because we want to do as much enteral nutrition as possible. And over time, the villi in what gut they do have is going to get bigger. It grows more. It's going to have more absorption area. So by using the gut, we actually give them more absorption through the gut, and just absorbing through the gut is better. When we give you TPN, the liver has to do all the breaking down and metabolizing that the gut normally does. So TPN is very hard on your liver. We cannot give you as much as you need through the intravenous route without doing some damage to your liver. So many of these kids over time will need an intestinal transplant if we can keep them alive long enough to grow where a transplant is possible. Some of them will need that. Here's a little girl with her Broviac, right? TPN is highly osmolar. It must be given in a central line. So she's got a Broviac in place. This is not the kind of dressing we typically use. We don't want to cover up. We want to use those little Bioderm antimicrobial patches and then a Tegaderm or something so we can see the site looking for infection, because the big issue with this is infection. Anytime we have a central line, we have a very easy portal of entry for infection straight into the bloodstream. So sepsis is a high problem. That's what these kids come into the hospital with usually, even families who are doing everything right. And we teach these families how to take care of that Broviac, how to change the cap, how to change the dressing, how to hook up that TPN. They also usually have a G-tube, a gastrostomy, so we're teaching the family how to set up a continuous gastrostomy feeding on a pump at night. They may be getting meds and other things through that G-tube during the day. So these families are taught a high level of medical care, and they are very good. They're not doing a poor job when the child comes in. How do you make a toddler be clean? You know, the kids play with stuff. They put their hands where they shouldn't, get them full of germs, and then touch other things. So it's really hard not to have them develop sepsis. So anything we can do that's going to minimize the possibility of sepsis is what we want to teach these families. I've seen some nurses kind of try and get the Broviac out of the child's way by putting it down through the Velcro part of the diaper. That is a poor idea. Anything going through or near the diaper is a poor idea, because the other issue is a lot of what we put through the gut, it doesn't have very long in the gut, right? It comes out quickly, so it hasn't had time to turn to form stool. So we have a lot of diarrhea on these kids. So don't get that Broviac anywhere near where it might get contaminated with diarrhea. Hydration when you're having diarrhea is an issue. Electrolyte balance when you're losing stool before electrolytes have been reabsorbed in the large intestine, right? That's where water is reabsorbed. Water and sodium, BFFs, they go everywhere together. So not only is sepsis a big issue, but fluid and electrolyte balance is difficult on these kids. And then just making sure they're getting adequate nutrition to grow without damaging the liver because of the amount of TPN. So it's a very precarious balance. On the other hand, these kids are so cute. They are absolutely normal little kids.